Associated Disorders, NIMH-TSS, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the Program Coordinator of NIMH-TSS. Marty?
Thank you, Kelly, and thanks to our audience for your patience. I'm pleased to introduce everyone to Martin Franklin, Ph.D., who is Associate Professor of Psychiatry at the University of Pennsylvania School of Medicine and Director of Penn's Child, Adolescent, OCD, TIC, Trichotillomania, and Anxiety Group. For over 20 years, Dr. Franklin has conducted clinical research projects on OCD, trichotillomania, Tourette syndrome, and related disorders. He is currently lead investigator on 3 randomized controlled trials funded by the National Institute of Mental Health. One study is on pediatric OCD with SRI partial responders. Another is a multi-center study on pediatric OCD examining treatments for children ages 5 through 8. And the third is a single-site study examining treatments for trichotillomania in children and adolescents ages 10 to 17. In collaboration with colleagues at Duke University Medical Center, he recently completed a pilot study of cognitive behavior therapy, or CBT, for Tourette's disorder in adolescents and young adults. He has presented on the psychopathology and treatment of pediatric OCD, trichotillomania, and related conditions in lectures and workshops both nationally and internationally, and continues to be active clinically in providing CBT for OCD and related conditions. He is also a member of the Science Advisory Board for the OC Foundation and the Trichotillomania Learning Center. It is with great pleasure that I now turn our program over to Dr. Franklin.
Well, thank you so much. I want to welcome everybody and also apologize for the technical problem, which was on my end. Technology and I often don't get along. But we're here now, and I want to focus the first part of the webinar on the definitions and assessment of trichotillomania. I then want to talk some about some related conditions as well, such as skin picking and nail biting. And then I want to talk about the cognitive behavioral interventions that we have been doing here and appear to be effective in helping kids and adolescents and adults as well who suffer from trichotillomania. So let me first begin with the content of the first slide, which is the current DSM-IV definition of trichotillomania. I've highlighted 2 criteria here, which is the tension prior to pulling or when attempting to resist, which is criterion E, and as well as criterion C, which is pleasure, gratification, or relief upon pulling. These are criteria that are not experienced by all people who pull. Sometimes people pull truly automatically without conscious awareness.
Dr. Franklin?
Yes.
I do not see your slides. What I'm going to do is I'm going to take the controls back and then give them back to you, and hopefully that'll fix the problem.
Absolutely.
Okay.
On my screen, right?
Show your, yes. Show under show my. It needs to say show my application, and you need to
monitor.
So where it says screen, you can click click on the thing that says screen, and we're looking for your. There we go. We got it.
Oh, yay. Okay.
Terrific.
So as I was saying, criterion B is tension prior to pulling. Criterion C, pleasure, gratification, or relief when pulling. I'm a part of the DSM-5 subcommittee, and these criteria may be removed when DSM-5 is published because we feel like they may not be applicable to all people who pull. They may especially not be applicable for kids who pull. Many kids do lots of behaviors they're not sufficiently aware of, nor can they describe well what the prompts may be. So these criteria may well be coming out. Bottom line is, if there's sufficient pulling with noticeable hair loss, not better accounted for by another problem that leads to clinically significant distress or functional impairment, then you may be talking about trichotillomania. Just a bit about the prevalence and gender distribution. It looks like trich is predominantly a female disorder, especially in clinical samples, where you'll see up to 95%, certainly in the adult trials, of the people who present for help are women. And when you look at the small epidemiology studies that have been done, it still looks like it's a predominantly female disorder. We don't know why that is. That raises lots of interesting hypotheses that can be studied in another context. Typically, when you're talking about onset of the disorder, we're really talking about ages 9 to 13, right before puberty. Although there's a subset of kids who develop trich as young as 12 months to 18 months and within that very early childhood period. Oftentimes that's in concert with thumb sucking and seems to have some kind of a self-soothing function. And what we don't know yet is whether very young kids who start pulling, whether they continue to pull or not. But we certainly in the clinic, we see people who have onset at both of those times. It's a bimodal distribution, and it may have some relevance. The younger the kid, the harder it's going to be to do CBT. So we'll talk about that as we describe the cognitive behavioral intervention. Got some information here about where people tend to pull. This is from the Trichotillomania Impact Project, which Doug Woods and myself and a number of other investigators launched some years back. This was an anonymous web-based survey of adults who pull. We had 2,400 adults self-identified who had trichotillomania, and also 336 parent-child pairs reported on the phenomenology of trich. And the one thing I would point out here is that scalp for both kids and adults, by far the most common pulling site. Eyebrows and eyelashes in both groups also fairly common pulling sites. Pubic hair is also an extremely common pulling site in adults, up to almost 60% in adults, and almost a little bit more than 1 out of 4 kids or adolescents are pulling hair, which actually is really important. This is an anonymous survey, so it might be easier for people to report on that using these methods. And I think it's really important to try to find out when you're working clinically with patients whether they're pulling, what all their pulling sites are. Because if you miss some pulling sites, you might be missing some important functions that pulling serves. So we use these information now, these data, to try to help make that question easier to ask. What I'd say is another thing that's interesting that came out of this is when you look at active pulling sites, about 60% of the kids, and the kids on average were about 14 and a half years old, about almost 60% of the kids were pulling from more than one site at a time, and 93%, vast majority of adults are pulling from they have more than one active pulling site at a time. Both adults and kids will describe, though, that pulling is usually of a single hair at a time. And we'll talk some more about that as we go into the treatment in more detail. What I have here is a description of hair pulling. I'm not going to read it to you. It's up on your screen. This is provided by an adolescent with trich. And what I would point out here is that there seems to be really clear evidence in her description, and there's clear evidence in the descriptions of many folks who pull, for a positively reinforced cycle. So it feels good in some way. People may dislike the consequences. They may feel badly that they do it. They may feel guilt and shame after the fact. Pulling. It appears that there's some pleasurable aspect for many people, and that's a very important thing to share with your patients so they don't feel like they are the only ones who like the hair pulling. That makes it easier to do your clinical assessments and also to do your treatment. Very important to get into that level of detail with them. What's the emotion when they pull? Trichotillomania, we know this is a public health disorder of relevance. It's associated with increased emotional distress and interpersonal conflict, sometimes even social isolation. There are medical conditions that are sometimes associated, skin infections from the pulling site, carpal tunnel syndrome from the repetitive behavior of pulling, and sometimes gastrointestinal symptoms. And what that leads you to wonder about is whether people are pulling the hair and eating the hair, which is not an uncommon response in trichotillomania. The majority of people who pull simply pull one hair and drop, pull one hair and drop, pull one hair and drop. We do know there's a lot of behaviors for a subset of people, rolling the hair in their fingers, sometimes holding it up and looking at it, sometimes biting off the root, and sometimes, in fact, eating the whole hair. Critically important to ask if that is indeed the case, because we know from information we get from the medical community that the human body does not digest hair well, and that can lead to what we call trichobezoars, or essentially hairballs that cause serious gastrointestinal and sometimes be problems and even be fatal. You see on the left the degree to which trichotillomania can affect people. This is not an unusual circumstance where most of the hair on the top of the head, the crown, is gone. And on the right, you see the consequences of eating whole hairs, which is you're looking essentially at a stomach and an intestine that's been completely filled with hairs. This is why you have to ask, because if these symptoms are going on and you don't know, people may be at serious medical risk. Really important to ask. Skin picking, a related problem, and there certainly are a continuum of severity. You've got some examples here of people who've been picking, and really quite a bit, leaving a lot of scarring and damage. What you know about with skin picking in particular is that people may tend to pick on spots that are already compromised in some way, either acne or scabs, and that may get them started to work on trying to even that off, and the more you do it, the less even it gets, and there's a perfectionism to that. Sometimes it leads to some pretty serious damage you can do. We do know also in skin picking that there's sometimes the use of implements, needles and tweezers and the like. In trichotillomania, especially with eyebrows and eyelashes, you also can see tweezers being used, and that's important to be asking about as well, just to make it normative and make it easier for people to describe what it is that they're doing and how it is that they're doing it. Because if you don't know that, you can't help. Just a very brief research slide. This is from the Trichotillomania Impact Project that describes and compares the depression, anxiety, and stress levels of individuals with trich from the Trichotillomania Impact Project versus a sample of individuals with obsessive compulsive disorder as compared to folks who have neither disorder. And what you see here is you see comparable rates of depression, anxiety, and stress in the folks with trich when compared to the folks with OCD on the same measure. So this is clearly something that you want to be looking for. This is an adult sample, and with adults I'd say that you would expect to see trichotillomania plus depression as being a very common comorbid condition and important to inquire about in your assessment. The relationship to OCD and to Tourette's syndrome, I'd say that trichotillomania and OCD share some commonalities. I think Tourette's syndrome as well. But I think the positive reinforcement, the pleasure, the enjoyment in some ways of the pulling process itself leads us to think there may be some different neural systems involved and some different learning mechanisms underlying both OCD and Tourette's as opposed to trichotillomania. But I do think you sometimes do see overlap and occasionally see somebody who's got both conditions. So that's something else to keep in mind. These things may well be you're at increased risk for one if you have the other. We're talking about assessment and treatment. I'm going to go quickly through that. I want to just walk you through how we do it, what we're asking about, and how the assessment leads to the treatment interventions that we do in cognitive behavioral therapy. When you're asking about a severity of hair pulling, one thing I would say is you want to be using a reliable instrument. And in adults, we have an instrument called the Massachusetts General Hospital Hair Pulling Scale. the MGH, which will give you separate scores, pretty short instrument, 20 items or so. I'll give you separate scores for severity, as well as severity of hair pulling, as well as resistance to hair pulling and perceived control over hair pulling. The child version of that is something we developed in the context of the TIP project, and that's the Trichotillomania scale for children. There's a parent version and a child version. We often want to get data from both, although we find in Trichotillomania that we have pretty high rates of agreement between parents and kids when reporting on Trichotillomania symptoms. We also will use, there's an instrument called the National Institute of Mental Health Trichotillomania Severity Scale, which is a diagnostic, a severity scale interview that's done by a trained rater, and that often becomes the primary outcome measure in trichotillomania trials. I'll describe that more in detail later when I show you the outcome of a study we did with kids. But bottom line is it's important to know how severe the hair pulling is, how much the person is actively resisting, and how much perceived control they have, and also how much it's affecting their day-to-day lives. Direct observation, we often will take pictures of the pulling sites before treatment and do so again when treatment is done. And sometimes we'll even ask people to save hairs as a method for us to make sure that our self-monitoring is accurate when we start that in behavior therapy. That can also sometimes be a useful behavioral strategy and intervention, which we'll talk about too. So you definitely want to get some information about the severity of hair pulling. You also want to talk about anxiety and depression, which we know are associated. So you have an idea before you start treatment where you should be starting. Because just because somebody has trich doesn't necessarily mean that you want to focus on the treatment on trich. You may want to address some of these other conditions as well. You're asking a lot of detailed questions about where they pull, how they pull, when they pull, what we call a functional assessment. The antecedents, so what behaviors and thoughts precede pulling, the exact behavior itself. I want to ask that in a lot of detail. So when you pull a hair, do you drop it or do you roll it in your fingers? Do you drop it and pick it up again? Do you drop it and leave it? Those kinds of things. So they help us understand better. And the consequences of pulling, what happened as a result of that pull? Did you feel some relief? Did you feel some pleasure? And that's going to also inform our intervention. We're very interested in whether the pulling is focused, meaning intentional, the person knows they're doing it, versus whether it's more sort of an automatic process. We've got a couple of instruments here for research purposes that we use to evaluate that. But I do, as a clinician, I definitely want to be finding out from our patients the degree to which they are aware of the pulling when it starts. Sometimes people may not notice they're started, but once they're started, it's hard for them to stop. We have to look at those things too. When we look at cognitive behavioral treatment models, we know, like many things, that pulling behavior is a function of antecedents, the things that precede, and consequences, the things that follow. So what happens? In trichotillomania, and oftentimes with skin picking as well, and sometimes even nail biting, you have a lot of visual cues that prompt urges. So the person looks at a hair, they look at an eyelash that's pointed the wrong direction, or they look at a scab on their skin and they think it looks like something they ought to fix. In trichotillomania especially, you have a lot of tactile prompts for pulling behavior. So the person's feeling around on their head, and they notice a hair that feels a little bit different than other hairs, or it's too short, or it's too long, and they have some sensation on their finger. Usually it's the index finger and the thumb, and they're having that experience, and that prompts the urge to pull. And then it gets difficult to stop that urge. There's sometimes emotions that precede pulling. Person's stressed out, quote unquote, or they're anxious, or they're sad. And they're going to be pulling in order to feel better. Sometimes it has that more intentional flavor to it. Cognitive. So a person might say to themselves, "I had a tough day. Let me just pull one, and I'll be better. I'll feel better." Environmental cues. So there may be things that you learn about the person's pulling that would suggest you can predict when it's going to happen, which is really important from a treatment standpoint. I've got people who only pull when they're alone. I've got people who only pull in the car. I've treated people who only pull in their bedrooms before they're getting to sleep. And that tells us where we need to target our intervention. The consequences I've talked about, positive emotions, pleasure, and some emotion regulation functions that you see and beliefs about pulling more likely in focus pulling. And the detailed information you're getting in the beginning of the assessment is going to tell you where you need to intervene. That's why we want to ask these questions in such detail. And treatments may target the various inputs to the system. So if I know a person has some automatic pulling and also some focus pulling, I'm going to try to target the automatic pulling via one method, but I'm also going to want to target the emotion-driven focus pulling with other methods as well. This is our manual from an NIMH-funded treatment development project we did. And what I'm going to describe going forward is the treatment, the summary of the book essentially, is the cognitive behavioral intervention that we developed and tested and has been used in adults and kids. Book cuts across all of those developmental ranges. With automatic pulling, so when the person's absent-mindedly doing the pulling while they're doing something else, often that something else is computer, telephone, reading, those kinds of things, driving in the car, sort of absent-mindedly pulling. With automatic pulling, you want to find out what those triggering preceding behaviors or situations are. You want to try to improve the awareness of those pulling episodes before they get started, ideally, but even right after they start as you first start working on it. And trying to provide strategies to stop the behavior when recognized. In general, you're trying to make the pulling more difficult. So if I know I have somebody who pulls in the car only, I may want to invest in some driving gloves that make that pulling more difficult to do. But I'm not going to know that until I do the assessment and really find out when pulling is occurring. Because it's not feasible to wear gloves 24/7, but gloves might work really well in the car when they're driving alone. With focus pulling, I'm going to need to find out some more about what emotions are leading to the feelings that, boy, I really have to pull, I feel awful. And I'm going to try to use coping methods to handle that emotion. There's some interventions more recently that target specifically the experiential avoidance, the tendency that many people have to not want to feel unpleasant emotions or unpleasant sensations or have unpleasant thoughts. And there's a whole school of thinking that Dr. Douglas Woods up at the University of Wisconsin-Milwaukee has actually done some work here, looking at the use of a treatment called acceptance and commitment therapy, using that to augment the cognitive behavioral interventions we already have with adults who pull. And he's in the middle of a treatment trial right now, which I'll talk about a bit later if I have the time. The core treatment elements, so you really get a good working assessment of when this person's pulling and how and what's leading to it, what happens as a result of pulling for them. You're going to have to spend a lot of time doing education, and especially in the context of families where they may not be even sure what this behavior is. A lot of education, awareness training, teaching the person to be more mindful, if you will, of when the pulling urges are happening. If you can teach somebody to recognize the urge, you can intervene faster using these methods we have here, which is stimulus control, methods to block pulling behavior. That may be, as I said before, the driving gloves, maybe Band-Aids on the finger, and it may be Band-Aids on the opposing thumb, the index finger and the thumb, which is usually where pulling is happening. A Band-Aid can interfere with the tactile sensation. Competing response habit reversal. This is something that those of us in the work in Tourette syndrome know a fair amount about, which is when you have the urge to do the behavior that we're trying to change, instead of doing that behavior, you do a physically incompatible behavior. So in the case of Tourette's, it might well be if a person has a violent neck shaking tic, you want them to tense their neck muscles slightly, hold their head at a 10-degree angle for 1 minute. In the case of trichotillomania, you're going to have to deal with the hands. So giving the person something else to do with their hands in response to those urges, getting them to be consistent about applying that, that's sort of the guts of the protocol, and we'll talk about its specific application going forward. And with kids, you may well need to augment the core treatment interventions with some stress management techniques or some cognitive restructuring to deal with negative thinking that leads to pulling for those kids. And with adults, there's a fair amount of work now in acceptance-based behavioral treatments and procedures for folks who are responding to strong urges and wishing to try to get rid of urges rather than go about their business. We'll talk about that as we go too. With self-monitoring, basically you're going to use whatever method you can. The younger the kid, the more you're going to have to be creative here. With adults and with teenagers, I might just set up an Excel spreadsheet that really asks, and I'm going to ask them to record what day did you pull, where were you, what were the triggering events, were you thinking anything beforehand, what was your emotional state, 0 to 10, how anxious or tense were you? And then really getting them to then write down how many hairs did you pull, what did you do when you noticed yourself pulling, what did you do after you completed a pulling cycle. And really this information can be used to help us understand better what we need to do. And it also provides some evidence of progress. If I know somebody's been pulling 100 hairs per day, and I do my intervention and 4 weeks later they're pulling 12 hairs per day, it's a nice way to represent for people how much progress they've made. Doesn't mean we want to ignore the 12 that are still there, but it's really a good way to measure progress. And every once in a while, too, you'll also see somebody who's just given self-monitoring to do, and you see a reduction in the symptoms because they're now more aware just simply from that process. With stimulus control, which is the way I think about it, is speed bumps. You're working with the person you're treating to develop different strategies to make pulling more difficult. Hats, bandanas, gloves, those kinds of things that they're designed to minimize or eliminate contact with situations or instruments that exacerbate pulling. And you're going to have to be creative and really use this as much as you can as a method to try to prevent urges from coming on to begin with. And when entering pulling-prone situations, you want to really make sure the person's been properly instructed and is on it, so they're using those methods as soon as possible. So if you're sending a kid to an auditorium where there's going to be a 2-hour speech, and you know that boring speeches are a risk factor for pulling for this kid, let's get the Band-Aids on before you even sit down. With habit reversal, this is, again, the use of a competing behavior. So instead of engaging in pulling, you're going to engage in another behavior. The earlier in the pulling process you can get this behavior implemented, the better off you're going to be. We've got people who use all sorts of things. I've had people shelling peanuts. I've had people knitting. I've had people simply clenching their fists in situations in which it's difficult to use these other things. I've had people use clay. And it's really just a matter of settling on the right thing for the person, something they can do that's feasible in different situations. And you may well have different competing responses in different settings. With social support, in addition, it's really more about getting the people in your life, and certainly it's in the case of kids, it's going to be parents. In the case of adults, it's going to be partners and everyone else who lives with you, to provide social support or reinforcement for use of techniques, as opposed to serving as the Trichotillomania police and yelling and screaming every single time the person's pulling, because what that does is it exacerbates stress, which then triggers stronger urges. So we don't want to be doing that. We want to change over to sort of noticing the person using their techniques, a more trick-neutral environment, which is the way Doug Woods has put it so nicely in the context of Tourette's. That's what we're trying to create, and some reinforcement for effort. With respect to the specifics of the habit reversal technique, you're trying to get them as much as you can to be more aware. Response description is getting the person to really be able to describe in a lot of detail what the pulling behavior looks like for them, to be able to identify this early warning or a pre-monitory urge, which is the way we put it in Tourette's, and response detection, becoming better aware to notice the behavior in other people. We do this in treatment all the time. I try to get kids and adults to notice when I'm moving my hand over my shoulder, for instance, because that's going to be a behavior that precedes pulling almost every time. The necessary level of awareness in habit reversal is not clear, but what I'd say is the better you can get them to be at being aware, the better off they're going to be, because they'll be intervening earlier and earlier in the pulling cycle. With respect to the competing response itself, I'd say that we want to try to get people to engage in that competing response, whether it's fist clenching or doing something else, for at least a minute until the urge dissipates. And what I tell people is, When you have an urge to do your pulling, I want you to engage in your competing behavior. Let's go for about a minute. After a minute, you come out and take the temperature of the urge. If the urge is still very high, you go back to your competing behavior. If it's not so high, you go about your business. That's what we're trying to get established in this intervention. I want the competing response to be incompatible with pulling, obviously. I want it to be less socially noticeable and interfering than the pulling behavior. And I really don't want to substitute pulling on one site for pulling on another, because it's too close to the behavior I'm trying to get rid of. So I really want to make sure I'm making some separation there with the patient. I want something they can do for a minute, and I want something they can do across multiple situations. And I may substitute in one for the other. People can't necessarily knit while they're in math class, but they could knit when they're watching TV. Those are the kind of things you want to work with. It's always a mutual decision. It's always going to be some trial and error involved, but it's a collaborative process, and you need the patient to be active and engaged in that process if you're going to make headway. We don't know, again, how much the social support matters. It's never been dismantled, but what I'd say is getting moms and dads and families to be less upset when the person's pulling and focused more on encouraging people to use their techniques, certainly going to be in the interest of everybody, and reduces stress and tension, which ironically enough may be another indirect pathway to reducing pulling. I want to show you just very briefly, before we get to the questions section, I want to show you what is the first randomized controlled trial for any treatment ever conducted in trichotillomania. This is a treatment study in which we compared the intervention I just talked about, which is essentially psychoeducation, stimulus control, and habit reversal competing response with these other modules involved, against what we call MAC, minimal attention control, which is basically three meetings over the course of 8 weeks, where really just check-ins, almost like a waitlist comparison. When you're doing treatment development work, you usually want to start with a relatively small sample and a relatively inert or inactive control condition, and that's what we did here. So this was 12 kids got randomized to the intervention, 12 kids to the minimal attention control, the MAC. Those who got randomized to CBT met weekly with their therapist, learned the techniques we just described. And at the end of 8 weeks, those kids then went on to an every other week maintenance phase where we really just focused on how are you using your techniques, has anything new come up. The kids who got minimal attention at the end of 8 weeks in this trial came out of the study and then were offered the open CBT. So we're really looking at a pretty small comparison of 12 versus 12. And we included in this study, because we're concerned about relapse in adults, we included in this study a 6-month naturalistic follow-up phase. So the kids stopped meeting with us, and in 6 months they came back and we looked at how well they were doing after 6 months of no treatment. And we'll look at those data in a sec. These were kids ages 7 to 17. They had primary trichotillomania, meaning it was the main problem. Their IQ was greater than 80. We do know we see trichotillomania and other body-focused repetitive behavior in folks with IQs lower than 80, but for this particular study they weren't included because we had a lot of other intervention techniques that would involve reading ability, etc. So we felt like that's a separate trial that should be done. None of the kids in this study were receiving medication. We wanted to get a clear test of CBT against waitlist. And none of the kids in our trial were diagnosed with these other conditions that might make it harder for us to test our hypothesis, which is that CBT ought to be better than a waitlist control, essentially. And let's see how we did. First thing I'd say is with our total sample of 24, these were a little bit younger kids. So they were 12 and a half. Their age of onset was 9, so they'd been pulling for about 3.5 years. 2/3 were adolescents, 12 and up. 2/3 were female, so we actually got more boys in this trial than one might expect. And 75% of our sample was Caucasian, which sadly enough is actually really good representation for a study in an OC spectrum disorder, where we rarely see non-Caucasian people enter the trials, which we don't really understand because the epidemiologic data would suggest that it's not differentially distributed. So it's an interesting and ongoing problem which we're hoping to solve. With respect to pulling sites, one thing I would point out here is we have 79%, so scalp being the vast majority. Eyebrows and eyelashes tending to go together. Eyelashes is the second most common pulling site. Not a lot of pubic hair pulling. This is a sample on age, on average of 12 and a half, so keep that in mind as you interpret that. And only 1/3 had more than one active pulling site. And so these kids are 12 and a half. The kids in the TIP trial were 14 and a half, and the adults, as I said, were on average in their 30s. It suggests some kind of a developmental progression. I think that's what I see here. We'd need a better study to do that. But it could very well be that if you can catch this early, when it's simpler, when it's more automatic, when it's only on one site, we may get better outcomes. So that's something that we wondered about, and I'll show you how we did with respect to outcome. The NIMH, which I told you about before, is an interview that looks at how much time you spent pulling, how much resistance to pulling, how successful are you when you resist, how much does the pulling problem bother you, and how much does it interfere with your day-to-day life. 0 to 25. 25 is the highest you can get. 0 means nothing, no symptoms, no interference at all. So when we look at how we did, minimal attention control, the wait list essentially is in yellow. And on the NIMH at pre-treatment, week 0, we see that their symptoms are actually a little bit lower than the folks who got randomized to behavior therapy. And we see to week 8, this is an 8-week trial, we see very little change in the wait list control, minimal attention, really not a lot of reduction of pulling. And that contrasts pretty dramatically with what we saw in behavior therapy, which is just about a 70% reduction in symptoms. So a pre-treatment score of 12 on the NIMH, and then down to a little lower than 4 at the end of 8 weeks. What's very encouraging here is we maintained through the week 16 maintenance phase, and also when we stopped the treatment at week 16 and then went to a naturalistic follow-up, the gains were maintained. This contrasts quite a bit with what you see in adults, which is often a return of symptoms of usually in about 50 to 60% of the people who entered the initial studies. So we're very encouraged by this, and it may well be an argument for early intervention. However, it's a small sample size. It's only 24 kids. With a larger sample, we might have been able to look at predictors of treatment response. We are unable to do that here. I'd conceptualize it as a promising start. And I'm not sure it's the best test. A minimal attention control we might expect, as we hypothesize, that we'd be better than that. But what we have now ongoing is a study in which we're comparing the same intervention, the cognitive behavioral intervention we talked about, to a psychoeducation and supportive counseling condition, which is exactly the same protocol, albeit modified to specify TRIC, the exact same protocol that was just tested in a study that came out today, probably a groundbreaking study called the CBT trial. It was published in the Journal of the American Medical Association today, and it shows the efficacy of habit reversal behavioral treatment for tics as compared to a good active control that includes education about tics. Did very well. And what we have going right now is a study doing a comparison of habit reversal against this supportive counseling intervention with a very similar idea, and really just trying to increase the number of participants and also look at prediction of outcome. So that's an ongoing trial. We're about halfway done. And we're still seeing kids ages 10 to 17. This is a little bit of an older crowd than the original trial. And I think I'll end my slides at this point. This is who we are, and I'm happy to take questions at this point.
Well, thank you, Doctor. That was really quite a lot of information, and we have quite a lot of questions.
Oh, good.
Yeah, well, I guess I need to say up front is it will get to as many as we possibly can. The rest will be answered on the chat board. And also, if we can try not to give too many lengthy answers, it might help us to, get through as many questions as possible.
Absolutely.
All of that being said, before we start the Q&A, I hope you'll all bear with me while I just take a couple of seconds to tell you personally about something that's really important to us here at NJCTS. It's regarding the slides that are currently scrolling across your screen. I don't know how many of you are soccer fans, but Tim Howard, the goalie on the American World Cup soccer team, also has Tourette syndrome, and he has picked us, NJCTS, as his charity in the Pepsi Refresh Challenge. This is an opportunity for NJCTS to win $50,000, and we are in a winner-take-all competition with some other very worthy charities. And we're thrilled that Tim has selected us, but now we need to enlist the help of everybody listening tonight to go to the U.S. Soccer website and cast your vote for Tim Howard. The link to vote is shown on the slide on your screen, and you can vote as many times as you like before the June 12th deadline. Please tell your family and friends and every soccer fan you know to vote often for Tim Howard and to put us over the top. So thank you for allowing me to do that little commercial. All right, I'm going to start kind of at the beginning with questions, and we'll get to as many as we can. Does the data regarding this behavior, we're talking now about trick, of course, speak at all to a history of being sexually abused? And does this in turn provide a coping mechanism of control?
That's a great question. And it's one of tremendous importance because I think it's misunderstood. And what I say is my data from the first study and from the second study and also from the CBT, from the TIP project would suggest that it's not. It would suggest that the vast majority of people who presented to these Trichotillomania projects do not have a history of sexual abuse. And it's therefore not necessary as a setting event for starting the pulling process. There are some people who do have a history of sexual abuse, and that's really important to find out about in the context of treating that person, but I'd say the modal person who is pulling does not have a history of sexual abuse.
Okay, good. How long does it usually last? Does it ever go away?
Those are good questions as well. I think we don't have the longitudinal studies of people who haven't been treated to be definitive about that. But what I would say is that trichotillomania is a stress-borne problem, and it's often, therefore, very responsive to stress. You see a fair amount of waxing and waning. What we have seen in adults is adults who get cognitive behavior therapy are typically doing quite well at the end of treatment. And you see about half of those people doing quite well who've relapsed over the course of 3-4 years. With kids, with the little data we have, which is what I showed you, which is up to 6 months, we had excellent maintenance of gain. So my question there is, if we catch it early, we may be in a better position to stem the tide of development and maybe increase the chances that trick is no longer a problem down the road.
Well, that would be wonderful.
Yes, it would.
We've had several questions about medication.
Yep.
So best meds to treat this condition?
Yep, I'd say this. I'd say that the medicines people would think about automatically and have used in the last decade in trichotillomania research are the serotonin reuptake inhibitors. The logic being this is an OCD-like illness, and therefore a treatment that is efficacious for OCD ought to affect trick as well. And the answer from that literature is not necessarily, and in fact I'd say the SSRI literature is not very positive. So those are, Prozac or fluoxetine and fluvoxamine and sertraline, generally not terribly efficacious on their own in reducing hair pulling. Sometimes they're used to treat comorbid conditions. So if a person has depression, they may well be taking the medication for depression, but I wouldn't expect much change in the pulling itself from using Prozac. About a year ago, however, there was a study done at the University of Minnesota by an outstanding investigator by the name of John Grant, who tested essentially a health food supplement called N-acetylcysteine. He tested that in an adult trial. 56 participants, I believe, were randomized to get the health food supplement. I believe it was 2,400 milligram doses at the max, comparison to pill placebo. And he got very good responses. He got the majority of the treated sample who got active medicine were considered to be much improved at the end of treatment as opposed to the negligible percentage of the people who got pill placebo. And what was interesting about that trial is he got not only reductions in hair pulling behavior, but reductions in hair pulling urges, and may well be that N-acetylcysteine is directly affecting urges. There's an ongoing study right now at Yale University. Michael Block is the principal investigator, who's now trying essentially the exact same strategy with kids. And that trial is ongoing. That was funded by the Trichotillomania Learning Center, which is the place to go if you're looking for help and assistance and information about trichotillomania. They're on the web. They're fabulous. And they funded Mike's trial. And by the time we're done, we may well see if we have another intervention to be effective for kids with trich. I'd say right now that's the most promising lead we have.
That's great. That actually was a specific question that someone recommended or someone asked, and you did give recommended dosages there.
24. You want to look at Grant's paper really closely. It was published in Archives of General Psychiatry in 2009, but I believe the dose was 2,400 milligrams. And John Grant is a really fabulous guy, and I think he's extremely helpful. And I'm sure if you contacted him at the University of Minnesota and asked a question, I'm sure he'd be helpful in providing an answer and recommendation.
Okay, excellent. Are there any other homeopathic types of things that you might suggest, or is this right now?
I'd say there are lots of things that are tried, and you have lots of people saying I tried substance X and it worked well for me. But in terms of evidence that makes me confident scientifically that there's an effect, I think N-acetylcysteine right now is the one of we're most confident about because of the level of evidence.
Okay. Another question from a mom with a 7-year-old that started pulling and eating since she was 18 months old.
Yep.
She says she has not seen her doing this lately, and her daughter says she stopped. Can the mom assume that?
I'd say it's not unusual for kids at the very, very young pulling points, 18 months to 4 years, that those kids seem, a subset of those kids at least, simply stop engaging in the behavior. So I think it's not an unreasonable assumption to make. It's certainly seen it in the literature. At the same time, you don't want to be hypervigilant, but if you do see signs that there is pulling going on, then you want to bring it up in a really sensitive way. And one thing I would say is this: if you see a kid with her hand on her head, that is not the right time to ask her. She's going to be defensive. She's going to be feel like she's been caught. And I think you're always better off having that conversation a couple hours after you've observed something, because you're going to be less likely to get accurate information from a little guy who feels like they're on the spot.
Yeah. Kind of get the knee-jerk no.
Yeah, of course not. Yeah. What hand?
Yeah. True enough. Okay. Does trich have anything to do with Tourette syndrome?
I think those are excellent questions. And I'd say that David Pauls, who's a geneticist at Harvard, Mass General Hospital, is very interested in that question. We do certainly see some overlap in terms of increased rates of trich in folks who have Tourette's and vice versa. Not tremendously high, but I'd also say that I'm looking very much at that point at the differences which I described earlier, positive versus negative reinforcement. The vast majority of people with tics will describe the cycle in a way that learning theorists would describe as negative reinforcement. So I have an uncomfortable, unpleasant sensation that if I don't release or relieve by doing my tic, is only going to feel more uncomfortable. A lot of times people with trich will describe an urge, but the behavior itself is more positively reinforced rather than negatively reinforced. And we feel like that has some important implications for the underlying neural structures and neural systems involved. And I'd say that there are more differences than similarities to me, although they obviously both involve body-focused repetitive behaviors.
Okay. I had a number of questions about hereditary. Is it hereditary? Is it common for more than one child to do? So maybe you can kind of generally touch on that topic.
Sure. I'd say this. I'd say that there's one twin study in trichotillomania that's been published. That was Carol Nowak and David Pauls and Nancy Cuthan a couple of years back. And that study clearly identified an increased risk for identical twins as opposed to non-identical twins. So we do have some evidence for things running together. We do certainly see families in which you see pulling behavior in one sibling and you see pulling behavior in another. You also see families where you see pulling behavior in one sib and you see nail biting or OCD in another. So there's, again, the familial relationships here as well. A lot of these genetic studies are tricky, though, in that if you are seeing pulling behavior in more than one person in a family, it's hard to separate out the effects of modeling and learning from the pure genetics of tricks. I think there's a lot yet to be learned there, and hopefully the work that's going on, sponsored by Trichotillomania Learning Center in the genetics of trick, will point us in a direction there. And what we always hope is when you find some genetic evidence that will improve our sensitivity and specificity with respect to development of treatment. It's always what we're looking for. So some relation back to how do we help people.
Okay. Along that same line, though, what about the possibility of trick passing this, a trick's parent passing this disorder onto the children?
Yeah, I think I'd say that you do have you certainly do have an increased risk if you have trick yourself. You have an increased risk relative to the population of having a kid with trick. At the same time, what I'd say is this: is who better to understand and empathize and seek help for a kid who's got trick than someone who's been through it themselves. And so I think in some ways that rather than looking at it as a risk factor, it also will be a protective factor. You'll do the things that were helpful to you and do less of the things that weren't helpful when you develop trick. And so there's some advantages there. But I think we flat out don't know the rates. So of every 10 kids of people with trick, what percent are gonna wind up having trick themselves? We just don't know. We don't have enough information yet.
Okay, but I like the idea that you understand it, so you're in a much better position to assist your child.
Right, and you may well not do the things that are probably going to make it worse, such as yelling at your kid or telling them how much it's breaking your heart when you see them pull. All of those things, which I think are well-meaning, ironically enough, increase stress. And when you've got a kid who's been dealing with stress by pulling, what's it going to do? It's going to increase the likelihood of pulling.
Yeah, yeah. I'm probably pronouncing this wrong, but this question came out of the pulling eating slide that you were talking about.
Yep.
And how do they handle the trick disorder?
Yeah, I would say this. There's a couple of decent recommendations out there. Richard O'Sullivan published a paper some years ago talking about what kinds of recommendations you'd make in terms of diagnosing the presence of a trichobezoar. He's got lots of specific things, sonograms as opposed to X-rays, etc. I'm not a physician, so I don't want to get into that. But I'd say that Dr. O'Sullivan has pointed us in the direction. What I look for when I suspect that there's hair being eaten is I'm looking for gastrointestinal symptoms. I'm looking for irritable bowel symptoms, if you will. I'm looking for constipation. I'm looking for other GI symptoms, difficulty, stomach pain, lower abdominal pain. Those are the kind of things I want to be asking about.
Okay.
And I'm also really upfront with people about this one because I know if they're of the assumption, especially if they're kids, if they're of the assumption that no one on earth does this besides them, they're less likely to tell you what they're doing. If you use all the information we now have from the IMPACT project and from all the studies that have been done in the last decade and say, look, we expect that somewhere between 10 and 20% of people are going to be eating at least part of the hair, I think it makes it easier for the kids to say, well, yeah, I'm like that too. So sharing the scientific information with people while you're doing assessment might make a hard question easier to answer. So I'd encourage clinicians to do that.
Okay. It seems that this disorder is more common among women. Mm-hmm. But we do have a comment from a male listener who says what he seems to do is he twists the hair and knots it and then plays with the knot and subsequently causes the hair to be pulled out.
Yep.
Is that a common form of trick? And of course, in his case, he gets his hair cut and the problem goes away until it starts to get too longer again.
Right.
But is that twisting and knotting a common form?
Those are very good questions. And what I'd say is this. I don't think we know what percent of people who pull also twist and knot. I would say this, that there are lots of people who play with their hair and don't pull. And so what I'd say is, for me, if I'm looking at someone who's eventually winding up with noticeable bald patches that they're concerned about, then if I'm doing habit reversal training, I don't want to do it at the point of the pull. I want to do it at the point of the playing. I'm intervening earlier in the chain in order to help that person. So when that hand goes up over the shoulder, that's when I want to get that person to be doing something else. Mm-hmm. What I'd say with respect to males versus females, there's some from clinical samples. Clearly, you see that. Even from epidemiological samples, you see female preponderance. There's a researcher at Purdue University, oddly enough, in animal sciences, who's been studying a behavior called barbering in mice. And what's interesting about barbering in mice, these are mice that pull out the hair of other mice and pull out their own hair. And what's interesting about that is it's female preponderance, about 1 in 100 per colony of a specific species of mice. And when you take them away from their colonies, they typically will then increase the amount of hair pulling they're doing on themselves. What's even more fascinating is the onset of that pulling behavior is right before puberty. So there's lots of hormonal hypotheses that are need to be looked at. But then it raises this interesting question: what about the males then? How do we understand that? It's a different disorder, and I think that Dr. Joe Garner at Purdue University is, in the next decade, I hope, going to be able to answer that question in animals, and hopefully by extension give us some working hypotheses to deal with in adults and also in kids.
Wow. Okay. Question about how long should you wait before seeking treatment. It mentions an individual who pulled eyelashes for a few months and then simply seemed to stop.
Mm-hmm. I'd say that you will sometimes see temporary relief, and oftentimes that temporary relief is associated with a reduction in stress, though not necessarily. If I see that pattern 2 or 3 times, and it starts to become reliable and predictable, and I'm worried that the next time I get stressed, I'm going to wind up doing this again, and I don't want to do it again, that might be a good time to go. What I'd also say, though, is that now cognitive behavioral interventions might be different than N-acetylcysteine in this regard, is that CBT really requires an active participant and requires somebody who's willing to tolerate some unpleasant urges as they try to refrain from pulling, is willing to come in and self-monitor, willing to change their environment to make it less conducive to pulling. So that there's a subset of people who are not going to be either able or willing to do that, and so that's also a consideration. Readiness for treatment in CBT is really important. Mm-hmm. And so if I have somebody who's pulling, who says to me, I just don't know if I'm ready to give up this particular habit. I know it's not where I want to be in 10 years, but I'm just too stressed out now. It's too much work. I don't think I'm going to necessarily offer the treatment at that time, because I don't want to burn the bridge I'm standing on. I don't want to get somebody into treatment that's going to turn out to be even more difficult than it would be otherwise, and have them conclude that CBT doesn't work. So I've actually, on occasion, tried to convince sufferers, and more often than not, trying to convince parents that this may not be the right time for your kid to do this treatment. It just doesn't matter to her yet. She's 9. She doesn't care about the social implications of senior prom yet. It's just not on her mind. And we may well need to wait her out until that functional impairment increases, if she's just not able or ready to view it as a problem worth working on.
Yeah. So they have to kind of get it in their head that they're ready.
Absolutely.
Kind of like losing weight, I guess.
Oh, yeah.
You have to be there.
Yes, you do.
Mentally. Okay. It's interesting, because the next question that came up is, as strategies for a 10-year-old who had stopped the tricotil, the trick, and replaced it with a skin picking.
Yep. Not at all uncommon.
Then shifted to scalp picking. The point is that they had been successful with CBT, with the original behavior,
right,
but then it was replaced with an alternative. So
right.
Would you talk about that a little bit?
Oh, absolutely. What I would say is you can conceptualize that as the development of a new problem, or a subtle shift in an old problem. And I like to think of it as a subtle shift in an old problem because it actually makes me feel like I can get traction sooner. They say, okay, look, we had so much success working on this behavior when it took this form. We just need to dust off our sheets. We just need to go back to the same old, same old. You know how to do this. I know how to do this. Let's get back to it. I think that's a different flavor for somebody to pick up with than somebody who feels like I made so much progress and now everything is lost. But from a readiness standpoint, I'd much rather somebody say, well, okay, yeah, it's not optimal that it's shifted, but now that it has, I know what to do. And I think that just sets a different flavor to the treatment. So my inclination is to, first off, it's not an uncommon pattern. And second off, I'd say the same interventions ought to be effective the second time, provided, of course, that you're paying close attention to how the person feels about the fact that they had a relapse. Because the idea of a relapse can sometimes, as you'd imagine, be pretty demoralizing and make people less likely to engage actively in the treatment, which, ironically enough, will reduce the effectiveness of the treatment. So you got to deal with that as a clinician too.
Yeah. Do you see that kind of feeling with a 10-year-old that they would feel as a failure with that?
Sometimes, yeah. I mean, and sometimes kids are sufficiently aware of what's going on around them too, where they know that mommy and daddy were really proud of me when I stopped and now I started again. And there's oftentimes that kids may not express it quite so directly, but there's some guilt and shame and, oh, here we go again, and it leads them to maybe not want to make the same kind of effort.
Yeah.
You're going to have to deal with that piece as you go, and you're going to have to deal with that piece of the family. So if you have a family saying, I can't believe you're doing it again,
yeah,
you've got to hop on that pretty quickly as a clinician, and really shift that language about what's happening towards this more positive, okay, let's get back to it. You know how to do it. I've seen you do it before. Really getting back into encouraging again as opposed to, oh my God, it's happening again. Why are you doing this to yourself?
Yeah,
so those are
negative.
all
yeah.
understandable, and yet at the same time, they're gas on the fire for anybody who's got a stress-borne illness.
Okay. I have a mom with a 4-year-old who is only skin picking currently.
Mm-hmm.
She's concerned that she's going to move to hair pulling. Is there some? Would you expect that? Do they go hand in hand? And what precautions might you take?
I say not necessarily. You do see some increased risk of one if you have the other, but certainly not. I think the majority of either skin pickers or hair pullers don't have the other behavior, even though you have an increased risk of one when you have the other. And I'd say the best thing you can do at 4 is you can see what kinds of creative solutions you can come up with for essentially doing some of the things we were talking about before, which is providing opportunities for competing response. So a kid who tends to do her picking or her pulling in certain circumstances, maybe we give them a little stuffed animal, or we find some other way to without making it a big deal, because at 4 they're not going to be able to actively participate for the most part in a CBT intervention.
Mm-hmm.
But you can find ways to use the principles. One thing I would say that Harry Wright at the University of South Carolina is a child psychiatrist who trained here at CHOP, and Harry has worked maybe more than anybody else in the world with people at this age range, 1 to 4 years old, with pulling. And one of the things that Harry would certainly do is he would look to reduce stress in the family about pulling first and about picking first. And then the second thing he'd be looking to do is to just overall try to reduce stress in the family in general. Because we know that can be a risk factor for kids continuing pulling. And if a family is tremendously concerned about it, it may affect their behavior. It may then lead them to be more upset in interacting with their kids, and maybe sometimes saying things or doing things that the kids pick up on as being stressful. They kind of get the idea it's bad, or I'm doing something bad, or I am bad, which increases their feeling of being not okay, which then increases their stress, which then increases their urge to pull and pick.
Sure. All right. I just want to mention we're losing a few people. I know we've kind of run over because we're a little late starting, so I just want to try and get to a couple more questions.
Sure.
But I do want to remind people, if you do have to leave before we finally end it for tonight, There'll be a survey that pops up when you log off, so please, if you would just take a moment and fill out the survey. And my other request is that you vote for Tim Howard, and don't forget to do that either. All right, I have a question. How do you motivate a child to want to try things to stop? In this instance, the child is eyelash pulling. He says it hurts, but doesn't seem willing to try interventions or to even stop when it's brought to his attention.
Mm-hmm. I think some of that depends on the age of the child, and some of that depends on the parent's typical response. And again, if you go back to something I said earlier, which is if the kid is not willing to stop when you point it out to them right in the moment, you may have just made that a little bit more complicated by bringing it up in the moment. So one thing I would say is conversations not in the midst of discovering pulling are probably more likely to be productive. I think that we have some ideas in cognitive behavior therapy as to how to improve readiness. We haven't tested those ideas yet in trichotillomania specifically, but my guess is getting people to looking at the pros and cons of pulling. That's something I would do fairly quickly if I wasn't confident I had somebody who really wanted to do the treatment. Mm-hmm. The pros of pulling sounds rather odd, and yet there certainly are some pros to pulling in folks who pull. It relieves stress. It makes me feel better. It's something I like to do when I'm bored. It's something that keeps me awake in math class. And giving voice to those pros will also help you to develop a more comprehensive view of what's happening and have a kid make an informed decision.
Okay. If you know when you're pulling but can't stop it simply due to the visual and the tactile issues, how do you stop it if you know, but the impulse is too strong?
I'd say the same way that you might change the rhythm of a pitcher. If you're a major league hitter, or even just any old hitter, and a pitcher is in a really good rhythm, one of the things that you see hitters do is they step out of the batter's box and they adjust their gloves and they do all sorts of things, and they try to get the pitcher out of the rhythm. So pulling tends to be rhythmic. And so if you're sitting on your bed and you're pulling and dropping, pulling and dropping, pulling and dropping, pulling and dropping, the urge is high, what I would suggest at that point is going from a high-risk place, which is sitting in your bed, to a low-risk place, which might be the presence of other people, going for an immediate walk to try to break the rhythm of trick. Another issue that comes up, and I think this is a really important one, which is the next time you're in that circumstance, you now know that you're in a high-risk situation when you're sitting alone in your bed and you're stressed and you're reading. You can probably anticipate that for next time, and you can probably do some preventive measures for the next time you're in that circumstance. So you may well have Band-Aids on. You may well have a bandana on. You may well not study in your room. You may study in front of the reference desk at the library to have other factors that are likely to reduce those urges working in your favor.
Okay. All right. What are the chances of the recovery of the hair loss?
I think they're really good. What I'd say is that you don't necessarily see it right away. We do take photographs as part of our treatment trials, and I don't even look at the photographs at week 8. Because if I've got somebody who's got a significant bald patch at week 0, if they stop pulling in the first week, I wouldn't necessarily expect that to be completely regrown by week 8. But I do take that photograph at week 16 because I expect that might be enough time for us to see some evidence for change. I think that telling people that it'll never grow back, A, is inaccurate, and B, might be a little demoralizing if they believe you. And so I don't think those strategies are advisable. But I do think that hair can sometimes change. Can get a little bit more wiry if it's been repetitively pulled. People have sometimes reported that. Sometimes I've heard about color changes and the like. But I say for the most part, the normative expectation is it'll grow back just fine if you leave it alone.
What about situations where you have male baldness anyway?
Yep.
I mean, in some cases, it may not grow back.
Yeah, that's right.
Because it's
well,
not
not.
going to anyway.
And I think that might be another reason, which you alluded to earlier, why maybe men are less inclined to go get help, because we've got a built-in excuse, and so it may not grow back, but people are sort of, they're going to shrug their shoulders at you and say, all right, well, you're getting older.
Yeah, and there's an expectation maybe, or a social.
Yeah.
Socially, it's less.
Right.
Less of a problem.
Absolutely,
Yeah.
and if I went to a crew cut tomorrow, no one would bat an eye at me.
Mm-hmm.
If my research assistant Aubrey went to a crew cut tomorrow, we might notice it a little bit more.
We might have a meeting.
Not necessarily. Aubrey's free to do whatever she wants to with her hair, but at the same time, it'd probably be harder. And my guess is that that's some of what drives. And again, it may well be that's one of the things that drives negative emotion, which is, look, I'm making this hole in my hair. I want my hair to look nice for this particular event, etc., which drives stress, which drives the urge to do a behavior that you do that helps you relieve stress.
I have a question about hypnotism. Have you ever heard of it being used?
Certainly I've heard of it being used. There was even a chapter on hypnotism in a nice 1999 book, edited volume. On Trichotillomania, sort of the definitive compendium of trick psychopathology and treatment. What I would say about hypnotism is we don't have any randomized controlled trials. And for me as a scientist, it doesn't mean it wouldn't work, but it means we don't have evidence that it would. And I certainly have heard individual patients go from CBT and then get hypnotism and feel like that worked more effectively. I've seen people come in here after hypnotism and didn't work and get CBT.
Uh-huh.
I don't draw any definitive conclusions in the absence of good data. What I would say in the absence of good data, it wouldn't be my first choice.
Okay, fair enough. We've talked a lot about hair pulling, and we have a question about skin picking.
Mm-hmm.
And are there any treatments there that you have seen to be successful?
I'd say with skin picking, Doug Woods at University of Wisconsin-Milwaukee has looked at it. Habit reversal training, which is very similar treatment to what we were describing. You just have to tailor it to the treatment of skin picking. Has been found to be efficacious relative to a wait list. I'd say there are not enough studies in skin picking to be terribly confident about any pharmacotherapy options. One thing I'd say with skin picking in particular that might differentiate it a little from hair pulling is the degree to which perfectionism is prominent. And there may be more prominent perfectionism in skin picking, which may well be one of those emotional setting events that you also would have to deal with if you're doing behavioral treatment. You have to deal with that urge to have it be just so, look just so, and feel just so.
Uh-huh.
As opposed to sort of the more repetitive behavior of pulling, which is it feels good, which is why I do it. I don't care what it looks like at the time. But skin picking, there seems to be more of that. And for me, with skin picking in particular, there's a lot of visual cues. And so if I have a person who's got skin picking vulnerability and their bathroom has lights in it you can land a small plane by, I want to get in there and I want to change those bulbs really quickly.
You want to take out that magnifying mirror, right?
Exactly. I want that thing in the backyard in a hole, because those are the kind of things that can be push and pull urges around a lot. I want to make the environment less conducive to picking as I can, and that's one of the ways to do it.
All right, I'm going to ask you one more question. We still have quite a lot of people left on the line, but we're really nearing the end here. So okay. One more. This is from a professional. I'm working with an adult client who pulls, and they've done everything that you've covered, mm-hmm. but her symptoms have not remitted. Mm-hmm. And she gets a sense that either she's ambivalent about changing or the impulse just feels too strong to resist. Yep. Any suggestions?
To me, someone who's talking about continuing high urges despite making behavioral change efforts, and using these interventions, that's somebody I would imagine that Dr. Grant would be interested in. And I think that NAC, N-acetylcysteine intervention is probably the most promising, I would say, alternative to CBT. There's one study by Nancy Cusin suggesting combined treatment with Zoloft plus CBT was more effective than CBT alone. For the subset of adults that she saw, I think a lot of them had comorbid depression, so we're not sure.
The number of minutes remaining in your conference is 5.
Oh.
If you need more time, the conference will automatically be extended for as long as possible.
I'm sorry, I'm glad we're on the last question.
Right, yeah, so be it. So Nancy's trial would have suggested that concomitant treatment with Zoloft, I believe it was, sertraline, plus CBT was more efficacious. That's another option. But to me, the most promising intervention right now in the pharmacotherapy realm is going to be this N-acetylcysteine. And that 2009 John Grant et al. Paper will describe in some detail the methods used and also the implications of their findings.
Okay,
That's
excellent.
the way I would go.
Thank you. Dr. Franklin, thank you very much. It was just a great deal of information. We have a lot of questions we haven't covered that will be handled on the chat board. So I'm going to sign off.
All right.
Thank you for joining our webinar on CBT for trichotillomania and obsessive compulsive spectrum disorders. There is an exit survey which should show on your screen as you exit. Please fill out the evaluation on the evaluation survey. The discussion board will be open, is open, and will be available for the next 7 days on the NJCTS website for additional questions that were not covered. That website is www.njcts.org, and it's under Wednesday Webinar Series. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation is on sensory processing disorders. It will be presented by Leslie Geyer and is scheduled for July 19th. Before you turn off your computer tonight, please join us in voting for Tim Howard's effort to combat stigma at the www.ussoccer.com/Pepsi refresh. This ends tonight's webinar. Thank you, Dr. Franklin, for your presentation, and thank you for everyone for attending. Good night.
Thank you.